so loud, I don't need a microphone. But thank you very much to my very dear friend, Zhishang Huang. Zhishang and I know each other so well that we insult each other all the time. It's a show of love and admiration. So, Zhishang, thank you very much for your comments. I want to be sure I have that. There we go. Okay. Well, good morning, everyone. It is truly a great pleasure and honor to present this keynote address. And I am only sorry that Professor Ken Wu is ill and cannot join us this morning. But I want to thank all of the organizers of this convention, this conference, for this very kind invitation, and to Peter Tsai for hosting us in our tour of Taiwan. It's my wife and myself, really our first visit here. And we've had a wonderful 4 days so far, and it couldn't have been better. So to give this address is really an honor. This morning, I would like to share with you the evolution of our prostate cancer care program at the institution that Zhishang and I work at, North Shore University Health System, which is a 4-hospital system just north of Chicago, academically affiliated with the University of Chicago. 4 hospitals, 100 outpatient offices, and 1 research institute where we work. And I'd like to share with you how we have grown our program from traditional prostate cancer care to personalized and now precision care. I came to North Shore University Health System in 2007 from the University of Chicago. And in building our program, it was important to first establish a strong integrated clinical unit, and in doing so, to transition from traditional to personalized cancer care. The traditional approach in the United States to cancer care is based on a standard one-size-fits-all approach that is physician-directed, single-disciplinary, and fragmented. You can see the unhappy patient at the top here, confused, anxious, being told what he needs but not being able to participate in the decision. The approach that we have adopted, and I think it's a much better approach, is comprehensive and multidisciplinary, where the patient is involved in the decision-making process, and we bring together all of the disciplines that impact prostate cancer care, involving patients in the decision-making process and integrating discovery into our clinical care. And discovery is really the key to our progress, because without research and discovery, things stay the same. In 2012, after establishing a prostate cancer clinic, we were very fortunate to open a brand new building in this outpatient center, the John and Carol Walter Center for Urological Health, made possible by generous philanthropic support from the Walter family. And in this new facility, we bring together all of the disciplines that impact prostate cancer care in this one office, in one building, including we involve the patient in shared decision-making using a web-based program. We have a cancer nurse navigator, we have a sexual health expert, we have psychological support, a nutritionist, and most importantly, we have translational research to go along with our clinical program involving urology, radiation oncology, and medical oncology all together. We have also been fortunate to be able to improve patient care by listening to our patients. In 2008, we formed what we call a Urological Health Advisory Council, which is comprised of about 15 of my former patients, most of whom are very successful businessmen in Chicago. The gentleman here to the left owns the largest restaurant chain in Chicago, and it's very successful because he treats his customers extremely well. So we tried, in developing our new center, to adopt the same philosophy of treating our patients as customers. Oftentimes we don't do that in medicine. I think it's a very important aspect of what we try to do. Our council has met annually for the past 10 years. We just had our 10th anniversary dinner 2 weeks ago. And the primary goal of the council is to improve the care we afford our patients, again, by treating patients like customers. This photo shows 2 of my former patients with me at one of our dinners, at which I was honored. You see the medal around my neck. I look like the lion in The Wizard of Oz. Remember the movie The Wizard of Oz? With an endowed chair in prostate cancer that their families generously donated. In the past 5 years, we have transformed our program from personalized, integrated, multidisciplinary clinical care to now precision-based genomic cancer care. And this slide shows the timeline for the development of our personalized to precision prostate cancer program. We have brought together clinicians and scientists with expertise in urology, genomics, pathology, cancer biology, computational medicine, and under Jishan Wang's leadership, biostatistics, and we have established a close integration between our clinical and research programs. In the past few years, we have developed a prostate cancer risk assessment panel based upon inherited or genomic DNA. Now, in most other hospitals, at least in the United States, precision cancer care focuses on patients with late-stage disease to identify the most appropriate chemotherapy with a goal of palliating and prolonging life. This approach, while important and worthwhile, benefits relatively few patients at the end of their lives. In contrast, the goals of the program which we are developing are to offer genomic risk assessment based on inherited DNA much earlier in life in order to develop precision cancer care strategies throughout the entire spectrum of healthcare, from screening and prevention, through diagnosis and through treatment, with the goals of reducing cancer mortality and improving quality of life, a strategy that potentially benefits all men and women. Again, our program focuses primarily on hereditary or germline DNA cancer risk assessment. Since germline DNA is inherited, it can be measured from a single drop of blood or saliva. It rarely changes during life, and testing needs to be done only once, maybe perhaps twice, in a lifetime. In contrast, somatic tumor DNA, which can be analyzed only after a cancer develops, suffers from the limitations that cancer mutations often change during treatment as cancers adapt, and also by the fact that somatic DNA may vary genetically between the primary tumor and the metastatic sites. Inherited cancer risk, our pyramid, so what we call our model is our pyramid model of cancer care utilizes genomic DNA to develop individualized prevention and screening and diagnostic strategies, and both genomic and somatic DNA for targeted treatment approaches in both early and late stage disease. Inherited cancer risk has been traditionally assessed by family history alone. Family history is indeed helpful, but unfortunately, it is often either unknown or incomplete. Our genetic risk assessment panel combines both genetic variations or single nucleotide polymorphisms, or SNPs, which are single point mutations which occur commonly and have low impact individually, and also high penetrant genetic mutations which occur less commonly but have a greater impact. The three components of the impact of these three components on inherited prostate cancer risk is shown in this cartoon of these different glasses. The average American man has about a 15% chance, shown by the red circle in the glass, of developing prostate cancer during his lifetime. That risk increases to about 25% if he has one or more male family members who have had prostate cancer. It increases to 30% if he has a combination of single nucleotide polymorphisms, genetic variants, or SNPs. It increases to 30%, shown by these little marbles, because individually they have a small effect, but together they can have a greater effect. And then the larger, we call ping pong balls, or tennis balls, are high penetrant mutations, and it increases the risk to 40%. If this gentleman has, if a man has all three, family history, elevated genetic risk score, and high penetrant genetic mutations, he has an 80% risk of developing prostate cancer. The importance of this approach is to be able to identify those men with an increased genetic risk and target them more aggressively for screening and diagnosis and treatment, and conversely, if they have a decreased genetic risk, to spare them unnecessary testing and treatment, and also unnecessary side effects and expense to our healthcare system. So we have developed a genetic risk score which combines over 100 SNPs into a simple ratio. The individual SNPs are weighted by frequency and impact into this ratio. Very simply, a genetic risk score, or GRS, of 1 indicates an average inherited risk of prostate cancer. Greater than 1, an increased risk. Less than 1, a decreased risk. Again, it can be determined from a single drop of blood or saliva. Saliva is good because patients who cannot come to the hospital can have their saliva sent by mail to our laboratory and analyzed. It's based on genomic DNA and therefore needs to be done only once in a lifetime. And it was developed, our genetic risk score, there are others available, but this one has been highly validated and recently commercialized, as I will discuss later. As shown on this slide, genetic risk score is more informative and more precise than family history. If a man has a positive family history of prostate cancer, his risk of developing prostate cancer during his life is 1.5 times greater than an average patient without a family history. And you can see as the percentile of the genetic risk score increases, the risk of developing prostate cancer goes up significantly, and those men in the highest genetic risk score have almost a 6-fold chance of developing prostate cancer. Again, genetic risk score doesn't replace family history, but like the glasses that I showed, it should be used in combination with family history. The genetic risk score modifies the effect of high penetrant BRCA1, BRCA1, and BRCA mutations in prostate cancer. The average risk of a BRCA2 carrier, hereditary BRCA2 carrier, is 40%. But that risk decreases to only 24% with a decreased genetic risk score, but increases to 70% if the genetic risk score is in the upper 5th percentile. In the past year, we have also identified several high-penetrant genetic mutations that distinguish lethal from indolent prostate cancer. And as those of you in the audience know of prostate cancer, one of the major problems for urologists such as myself in treating this disease is that most of the prostate cancers that men develop are not lethal. And most men with prostate cancer die with the disease and not from the disease. But there are a smaller fraction of prostate cancers which are very aggressive and very lethal. And as I always tell the audience when I'm speaking, ironically, I lost my best friend to prostate cancer 3 years ago. I am sure that he had a genetic alteration, mutation, but he didn't know about it. And so he was not tested early enough nor treated aggressively enough, and he died within 5 years after diagnosis with prostate cancer. So, and he was a physician, did everything right, and nothing worked for him. So, recently in the European Journal of Urology, we published a paper showing that high-penetrant mutations in the genes ATM, BRCA1, and BRCA2 occur more frequently in lethal prostate cancer and are associated with both an earlier death following treatment and death at a younger age. Indeed, men carrying one or more of these mutations have a mean survival of only 5 years compared to 15 years in men who do not carry one of these mutations. As shown on this slide, high-penetrant genetic mutations are predictive of prostate cancer overall survival in both men with localized, to the left of the slide, and metastatic prostate cancer. High-penetrant genetic mutations are also associated with an earlier death from prostate cancer following surgery and death at a younger age. And I should acknowledge our collaborators from both Johns Hopkins University in Baltimore, which has the largest prostate cancer series, surgical prostate cancer series in the world, and also Fudan University in Shanghai, which also we have collaboration with because of the director of our precision care, cancer care program, Jinfeng Xu. We have also recently shown that our genetic risk score, although less impactful, genetic risk score here, high penetrant genetic mutations here, although our genetic risk score is less impactful, it is also an independent predictor of survival following surgery. Very importantly, in the last year, under the leadership of one of our young urologists, Dr. Brian Helfand, who is not only an outstanding prostate cancer surgeon, but also a basic scientist with a PhD in cancer biology, we established a prostate health clinic in our new urological center in which genomic risk assessment is incorporated into clinical care. In this new clinic, we incorporate both commercially available biomarkers and our recently developed genetic risk score and what we call inherited cancer panel into all aspects of prostate cancer care, from prevention and screening through diagnosis and treatment of both early and late-stage disease. The next 3 slides depict an actual recent patient history. A 55-year-old man presented to our prostate health clinic with newly diagnosed prostate cancer. He was healthy except for a past history of lymphoma. He had a mildly elevated serum prostate-specific antigen or PSA level, and his biopsy showed very low-risk disease, only 1 out of 12 biopsy cores positive. Our concern and our question was whether this young, otherwise healthy man with clinically very low-risk prostate cancer should be offered active surveillance or immediate treatment. He subsequently underwent genomic health care assessment. A careful family history revealed that several of his other family members had a history of not only prostate cancer, but also breast and pancreatic cancer. His genetic risk score, again determined from a panel of over 100 SNPs that are specific for prostate cancer, his genetic risk score was almost 3 times normal, 2.8. And he tested positive for a BRCA mutation. Because of his increased genetic risk, we therefore recommended that he undergo treatment. So he underwent a robotic radical prostatectomy, and as genetically predicted, his cancer was far more extensive and more aggressive than would have been predicted from his biopsy. Fortunately, although his cancer, as shown in the dotted line, involved microscopically both lobes of the prostate and extended beyond the prostatic capsule and into the adjacent seminal vesicles, fortunately his PSA level has remained undetectable post-operatively, and he has regained both urinary and sexual function. And very importantly, this information is now being used to test his family members who are currently undergoing genomic cancer risk assessment. And we have recently, just in the last 2 months, established a commercial collaboration with Ambry Genetics, which is a large, high-throughput clinical genetics testing laboratory in Southern California. And our collaboration with Ambry Genetics has 3 primary goals. 1, to continue to develop novel germline tests. 2, to develop supporting tools for implementation of all these tests. And 3, to carry out clinical validation and further genetic research. We are very excited about this new partnership because our laboratory is relatively small. And our goal is not only to be able to offer it to our patients in the local communities, but across the United States. And we hope to be able to partner through the flagship program with Taiwan and work together to improve and offer these tests across both our countries. Our partnership was recently announced in the press, and we are proud about this as a quote for a blueprint for precision medicine. This slide outlines our future goals. We are proud of what we have accomplished in the past 5 years, but we have so much more to do. First, we have recently developed a 21-gene prototype of a somatic DNA panel, and are in the process of validating and improving this test. For those of you who are not familiar with prostate cancer testing, although there are indeed several currently available, several RNA-based tests following treatment to assess the risk of disease progression. And these tests are known commercially as Prolaris and Decipher, and there are others. To our knowledge, however, this test, when commercialized, will be the first somatic DNA prostate cancer test. And somatic DNA has the advantages over RNA of being more stable, less expensive to analyze, and also, most importantly, because specific DNA mutations, such as copy number alterations, occur very early in carcinogenesis, making DNA analysis very worthwhile in men being considered for active surveillance. Now, we have several other cores in our precision cancer care program. Our cancer biology core is led by Dr. Simon Hayward, who visited with you last year. And he works closely, he and his team work closely with our genomics core to understand how genetic alterations alter the metabolic pathways to promote prostate cancer development and growth. The focus of our cancer biology core is somewhat unique. Rather than focusing on the cancer epithelial cells, we focus primarily on the tumor microenvironment, and our specific interest is cancer-associated fibroblasts and how they affect cancer metabolism and growth. Based on this information, we are working to develop medical treatments, drug treatments, to stabilize early-stage prostate cancer and prevent it from progressing, thus making surgery or radiation therapy unnecessary. As you know, conventional chemotherapy often employs single agents in high doses, which can be associated with significant side effects. Our strategy is to use combination low-dose medications to inhibit growth factors in the tumor microenvironment, such as the cancer-associated fibroblasts, and thereby stabilize early prostate cancer with minimal toxicity. Dr. Susan Crawford, who heads our research pathology core, has also begun to gain insight into the genetic alterations associated with obesity and cancer growth. Normally, there is a finely regulated balance between lipogenesis, or fat storage, and lipolysis, or fat breakdown. In order to meet the increased energy requirements in prostate and other cancers, lipogenesis is favored over lipolysis, allowing cancer cells to accumulate excess lipid. We have recently shown that the gene coding for the lipogenic promoting protein, DGAT1, as shown in this seesaw here, DGAT1 is overexpressed in 40% of all prostate cancers, favoring fat accumulation, as shown in these photomicrographs at the bottom of the slide, with the fat around the prostate epithelium. And it's also overexpressed, DGAT1 is overexpressed in 25% of the lethal prostate cancers that we have studied, far more than in indolent prostate cancer. So it may be possible to develop targeted therapy to inhibit DGAT1 expression. Precision medicine, the era of precision medicine is just beginning, and it can be readily expanded to other cancers, such as breast cancer and other diseases including diabetes and cardiovascular disease. To date, we have currently validated our genetic risk score in breast, colorectal, and pancreatic cancer, and we have preliminary evidence in other cancers as well. This slide of a hypothetical male patient depicts that he has an increased genetic risk score, indicated by the horizontal red bars, for 6 different cancers. Knowing this information may be helpful in developing targeted screening and prevention and diagnostic strategies so that he can be diagnosed before his disease becomes clinically aggressive. Similarly, we have recently learned that high-penetrant genetic mutations now occur far more commonly than once was realized. For example, 19% of women carry a high-penetrant mutation for ovarian cancer, and 9% of women carry a mutation for breast cancer. Our future goal is to make genomic risk assessment for cancer and other diseases available to all men and women at any stage of life, and thereby direct our healthcare resources towards patients who are at increased risk and most likely to benefit, and while sparing those individuals with decreased inherited risk unnecessary treatment, test, and cost to our healthcare system. Indeed, at our institution, we are currently conducting clinical genomic testing and trials in breast and colorectal, as well as prostate cancer. And focusing on breast cancer for a moment, in the United States, these are the most common cancers, solid organ cancers, in women and men respectively. And the incidence and mortality is interestingly very similar. These pies of the incidence on the left show the entire cancer cases of over 1 million per year. Breast and prostate deaths, very similar. And in addition, breast, and I've always been interested in the fact the similarities between the two diseases. Both breast and cancer are not only incidence and mortality, both are secondary sex organs that develop at puberty in response to hormones. Neither organ is essential for life, but both serve important reproductive functions. Both cancers metastasize primarily to bone, and both cancers are treated in their advanced stages with hormonal therapy. So we are just beginning. It is so exciting, but because I'm a urologist, we have focused initially on prostate cancer and the team we have developed, but everything we're doing can be applied to other cancers. And the interesting and positive thing about cancer is that if you detect it early, most cancers are curable, as opposed to other diseases perhaps which we have no treatment for, such as Alzheimer's disease. But for example, pancreatic cancer in the United States, the 5-year survival is less than 5%, probably 1 to 2%. But if you target screening with ultrasound or CT scan, the cure rate with pancreatic cancer goes above 40%. So we can do much better if we know who is at risk genetically. So we are very excited, in conclusion, about our potential to collaborate with the National Health Research Institute in Taiwan. And we view the goals of our collaboration to be to partner in genomic research, to compare genomic differences between our different populations, to share our discoveries with our colleagues internationally, to collaborate with industry, both in the United States and Taiwan, to commercialize our genomic tests, not with the goal of making money, although that's probably the goal of the company, but our goal is to establish nationwide networks of genomics testing in Taiwan, USA, and other countries, and ultimately, and far more important than the economy of it, is to improve patient care through personalized medicine and with a genomic-based precision approach. In closing, I would like to acknowledge my colleagues at North Shore University Health System. The names are mostly unfamiliar to you, except for the name at the bottom. And I always tell Chisang I put him at the bottom, he goes last. But it includes both clinicians and scientists. So the top person is our Chief Scientific Officer, our Chairman of Surgery, Mark Talamanti, the Director of our Prostate Health Clinic, who is a urologist and also a cancer biologist, and then all of our scientists who work together in our program for precision cancer care. The collaboration between the clinicians and scientists and the support of our administration has been critical to the success of our program, and I hope to yours as well in the flagship program. And in conclusion, again, I want to express my great gratitude to all our hosts. Again, I am sorry that Professor Ken Wu is ill and could not join us today. And I hope that he will benefit from the findings and the progress we make in our Congress. Dr. Paul Chang, who incredibly warm welcome. We had a wonderful dinner last night, and very special. And also, of course, to Peter Tsai, who has just been an incredibly gracious host for my wife Lucy and myself. And then, of course, I had the pleasure of meeting Ms. Wei Chen Pang this morning, who's done everything, I think, for this conference. She must be exhausted, but she's done such a wonderful job. I must have had 400 emails from her telling me, reminding me to get my abstract in, so thank you very much for everything. And then finally, I want to acknowledge my wife, Lucy, who's in the audience. First, she came this morning. I always want her here for good luck. But she also comes to be sure my tie is straight, my hair is perfect. And so we've been together almost 54 years, and so I couldn't go anywhere without Lucy. And on behalf of both of us, I just want to express my great gratitude to all of you. This is an incredibly wonderful experience for us. Thank you very much.